I'm going to talk about HSGs and their interpretation. That's what he asked me to do. So as his good friend, I'll keep doing what he wants me to talk about. I live in the beautiful Pacific Northwest. I also am part of the University of Louisville reunion here, and he was I was a third-year fellow, and he was a second-year fellow, and I migrated to Seattle. And this is not me, but I just have no disclosures, so I don't make any money at all outside of what I do. And I'm going to talk about these several things: hydrosalpingx, loculations, intrauterine adhesions, uterine anomalies, fibroids, and endometrial polyps, which are typically diagnosed on an HSG, which is your initial test that you do as part of the standard fertility workup that Steve talked about, and then take it from there in terms of management. I'm going to talk about Müllerian anomalies. Those are just uterine anomalies. They're common, or at least you should at least be thinking about it as part of the fertility workup. They can contribute to the issues that we deal with: fertility, pregnancy loss, poor pregnancy outcomes. And their diagnosis is basically physical exam, which is what we rarely do nowadays with Zoom and all that. But we do imaging, ultrasound, saline that Dr. Nakajima talked about. And you should have this as your repertoire of imaging whenever you're doing HSGs. You should have a strong relationship with whatever facility that you use. If you do it at your own facility, great. But definitely, if you don't, you should have a phone call, a red phone to call, because these can be tricky to diagnose. So, what we're looking at here, right? So this is an HSG, obviously, and we're looking at a lot of pathology there. The tubes are obviously obstructed. The uterus is obviously different. It's not supposed to be like that. And so you're going through your differential of like what's going on there. And there could be a septum, it could be a bicornuate uterus, there's blocked tubes, and you just kind of need to figure it out. And that's what the HSG does. It just initiates discussion about what's ailing this couple and struggling to get pregnant. So just throw out a case scenario. Typical patient that we see, 37-year-old trying to get pregnant, has multiple issues, PCOS. I didn't check an AMH, but maybe I should, Mahar. But she has PCOS just based on clinical symptoms. And then she had her HSG, and again, we're kind of looking at that going, what's going on? And so, blocked tubes there, and we have to do a ultrasound, right? And an ultrasound is probably the next. This is a transverse view. Kind of threw a little red flag at you, but this is actually not a septum, it's actually a fibroid. And you can see here, but that's what typically, this was interpreted by the referring physician as a septum, but there's actually a fibroid. Is this translating? No. There's actually a fibroid right here. You can see it. And it's deviating the cavity, but that's what typically is shown initially on an ultrasound, and then you have to clarify things with an MRI. So you can see here, it's this is the uterus right here. So you got to get good at interpreting MRIs. I actually see my own MRIs. I go through the logistics of, I don't depend on the MRI report. I always ask for the CD-ROM or PACS image or whatever, but you can see here the septum right there, and the distinction between a heart-shaped uterus is differentiated by the fact that the uterine fundus is singular. And this is more demonstrated here. It's important to distinguish between this and this because the surgical managements are very different. This you can easily surgerize, hysteroscopy, you go up. Here, a little bit, it's a metroplasty and a little bit more involved, but you have to literally break down this uterus and put it back together. So it's a little bit more involved. And the indications to do that type of surgery are obviously recurrent pregnancy loss. And so you need to differentiate, because if you start cutting this on a bicornuate uterus, you're going to see bowel, and you're going to call Paya, and he's going to try to help you out because you just made a complication. But you need to make sure that the contour, what's going on the outside, and you could see that an HSG is very limiting in terms of what's going on here, because when you're looking at this, you don't really know, and you need to do all the imaging to make sure that you're dealing with the right uterine anomaly. So there is this distinction, arcuate uterus, and you need to know this terminology because radiologists, they use this terminology a lot, and it's written down in their reports and stuff, and you need to distinguish. What they call an arcuate uterus could be a septum, and vice versa. What could be a septum could be an arcuate uterus, and these are actually managed very differently. So with a septum, you obviously surgerize because it's associated with reproductive loss, but this is actually nothing to worry about. And your patients are going to come to you and they're going to freak out like, oh my God, I have an arcuate uterus. But the literature demonstrates that there really is no impact of an arcuate uterus on outcomes, reproductive outcomes. And this is a recent study done out of Colorado. Eric did this, and he took euploid embryos, the classic, sentinel event for implantation, and found that there was no difference in reproductive outcomes with arcuate uteruses versus normal uteruses with the implantation of a euploid uterus. So arcuate uteruses need to be left alone. And you can go in and surgerize it, but you're really not doing anything in terms of their reproductive outcome. So this is how it's done, and you can see my technique here. I use cold knife there, and what I'm doing is I'm demonstrating the line between the ostia there, and I'm coming in from the bottom down because your angle has to be very precise, and if you're at the wrong plane and you encounter bleeding, you're in the wrong plane and you should stop cutting. Okay, so that means I pause there because I started bleeding, so now I have to go down below. And this is a very actually simple procedure. Most gynecologists should be able to do this type of surgery. So, and you should use cold knife, okay, for exactly the reason I just told you. And I actually do this under ultrasound guidance. I have the luxury of having an ultrasonographer tell me how far I am away from the top of the uterus. I take the tips, I ask her how far am I away, and until I'm about 1 centimeter or so away, I stop cutting. That's how I know when to stop. And you can see that I'm drawing that imaginary line between the ostia. That's the plane that you want to kind of be in when you resect that. And you can see the bleeding that I'm encountering is because I went too far anteriorly. Okay, so does width matter? And you can see, I mean, it's pretty wide. So you're like, oh, shoot, is that a bicornuate uterus or a septum? People have looked at that and seen the width of it, but it actually is a septum, and so you need to follow it up with an MRI, or if you have a really good ultrasonographer and ask for multiple transverse planes, or if you can do it yourself, you can actually turn the transducer the right way and be able to demonstrate that that is a septum and can be resected. All right, so guess the anomaly. So again, keep an open mind. There's a lot going on here. You got obviously open tubes. You got the cannula in here. Is this a septum? Is it a uterine didelphys? Is it a bicornuate uterus? Who knows? You don't know. And so you need further clarification. You got a lot of things going on in there, and you have to clarify it with an MRI or an ultrasound. I actually use both, honestly, and the indication, people ask me, well, when do you pull the trigger on an MRI? When you don't have the information that you need from the ultrasound. And you can see here that it's actually a uterine didelphys right here, double cervix there. You can actually demonstrate this on a vaginal examination, but it can be tough because when you put the speculum in and there's maybe an undiagnosed longitudinal vaginal septum, And because the woman has had regular intercourse, the vaginal septum can be pushed to the side, and you can actually miss and think that it's a single cervix when there's actually a small vaginal orifice, and you need to go in that side to see that. So MRI really clarifies this. And I get asked this, longitudinal vaginal septums are oftentimes concurrently a diagnosis. You have to think about that. This obviously is a Netter diagram, but this can be pushed to the side and can be easily missed. So then when you go in, a pap smear has been done, the gynecologist says, oh, there's one cervix. It could be actually pushed to the side, and there's actually another cervix there. So you got to be careful about the physical exam and follow it up with an MRI. And I get asked a lot about this. Should I go in and surgerize this because she's had losses? She's had losses. These are always going to be associated with increased losses. And the literature is not very specific about it, but it's probably going to be double or triple. And a lot of people talk to me about, oh, can we go in and do a hysteroscopy, poke a hole through that? I've seen that. You're going to encounter a lot of issues with that, and you're not really doing anything because there's no literature in terms of, is that making a difference at all? So I strongly discourage any surgical intervention in regards to a uterine didelphic uterus. So the management is no surgery. Even when there's a fusion at the top, I do not promote that. And if someone comes, if you're thinking about it, it's best to just leave it alone and not do anything. All right, so here's another case here. You can see the cannula, scalp film. Okay, looking a little weird there. What's going on there? There's a tube, I think, maybe. All right, now we got the uterus. Okay, so the uterus is showing up there. Any thoughts, anybody? No? Okay, so there's a left tube. It looks somewhat normal, right? Looks somewhat normal. Is it a tubal blockage? What's going on there? Okay, any thoughts? Didelphys, yeah. So